All right, everybody. Thank you for joining us today for another VITA learning webinar. Today, we are going to be talking about implant restorative materials from high aesthetic to heavy load situations by Dr. Julian Conejo. We're very pleased to have him here today. Before we get started, though, I'd like to go through a couple of things that during the presentation, your phone will be on mute. We've got a lot of us today, so if you guys have questions, please type the questions into the little question box on the side there, and Dr. Conejo and I will try and answer them as best we can. And we will also leave some time at the end for more questions. This workshop will be recorded and we will post it on our VITA Learning website so you guys can go back and review it. If anybody needs a link, please contact us and we will send it after it is after we're done. If you need CE, you will get an email automatically from registering for this. We will send you an email about CE that will help you get those. If you have any questions about that, of course, you can email us and we will make sure and get you your CEs. Also, visit us on our social sites. There's lots of other videos on our YouTube page. And of course, if you guys have questions, please feel free to give us a call, myself or my colleague Jim, at our technical support hotline. All right. If you're ready, Dr. Conejo, then I am going to switch you over and we'll get started. So real quick about Dr. Conejo. Dr. Conejo obtained his DDS in Costa Rica in 2005 and his prosthodontist in Mexico in 2008. He's a visiting scholar at the Department of Preventative and Restorative Sciences at the University of Pennsylvania, Philadelphia. He practices clinical dentistry and conducts extensive research at UPenn. And from his research and experience, he's written several peer-reviewed articles and studies. It is a pleasure to have you today here, Dr. Conejo. Please take it away.
Thank you, Paul. Thanks again for your kind introduction. And I will just switch it here to share my screen. And before we get started, you can please confirm. Yeah, I think we're all set, right?
Looks great.
Great. Okay, perfect. So thanks everyone for joining the VITA North America webinar sessions. This is my third time. And it's always very, very nice to have the opportunity to share both our clinical work and our research work as well. And thanks, Paul, for hosting me today. And I will be presenting today on implant restorative materials. So the idea is that we can make this interactive. Please, any questions, comments, just put it on the chat, type it there. Paul will be reading those at the end, and we're gonna dedicate some time for those important Q&A questions and comments that really makes the whole webinar much more interactive. Okay, so Paul mentioned, now I'm a full-time faculty at the University of Pennsylvania School of Dental Medicine, and I am the clinical CAD/CAM director. I've been working with CAD/CAM technologies since January 2010. And as a prosthodontist, I've always liked and enjoy having time in the lab and working, and I had so many questions on the different materials, and now being able to combine it's something that I really enjoyed, trying to look for all those answers. So today, I'd like to try to combine as well from showing you brief studies and why we use certain materials in certain ways, but also directly linked to the clinical scenario. Okay, so before we get started and talking about the restorative materials, I think that today in 2021, we need to make sure to use all the available tools that we have for providing the best dental implant workflows for our patients. And I just published a chapter in the Dental Clinics of North America titled The Digital Clone. And it's basically how I capture the information for better and easier treatment planning. So we use intraoral scanners every single day. So those pre-op impressions will just go ahead and make an intraoral scan, the lower, upper arch, and buccal scan. If the patient is a dentulous, then I will also add another catalogs scanning whatever existing dentures the patient has, something that can help me correlate the maxilla and the mandible. And then we're going to be focusing, of course, in doing CBCT images to get the three-dimensional view of the hard tissues as well. But very important, being able to stitch these two together and make these kind of club sandwich, as I call it. And we have nowadays multiple different excellent implant planning softwares where we can really go to the finest detail on prosthetically driven implantology. And that's one of my favorite phrases, prosthetically driven, meaning that first I start with an ideal scenario of what I want to achieve regarding my prosthetics, an ideal digital WhatsApp. And from there, I look for an infrastructure for the implant, correct size, length, position to support that restoration. So I think that this is the most important part to start, because this is the foundation of everything we do later on with the different restorative materials that we have. And why I think that today most implants should be placed with computer-guided surgery, because if you see the survival rate from this systematic review for 14 clinical studies, the survival rate of almost 2,000 implants is 97.3%. So that's very high for every clinician out there. Having that percentage of survival rate on all your implant restorations would be awesome. And the reason for this is that if we first plan the prosthetics and then we look for a good foundation for these prosthetics with ideal implant position, length, width, etc., angulation, those restorations tend to last longer. Okay, so we got to start going from the wax up and then going for a great foundation, and then we move for the ideal material for those final restorations. Of course, making sure your intraoral scan is really clean, the CBCT file as well, patient is not moving, there's no distortion, so you can get a very nice correlation. Will help you minimize the error. I'm not saying that every implant placed with a surgical computer-guided surgery would be flawless, that there won't be deviation, but we can minimize the deviation by the quality of the information that we give to the software. So that's something very important to always consider. Okay, so there's many different softwares out there, but today this is basically what we try to do with whatever software you have. We take the intraoral scans, we decide if we're gonna reestablish the vertical dimension or not, if we want to transition from that MIP position to a centric relation, and then we go ahead and create a digital wax-up, an ideal digital wax-up, where we reestablish the cervical margin of those future restorations. And once we have that, then we merge these two files with the DICOM file of the CBCT, and that's how we really can achieve this level of precision. So the digital clone is based on what it's been called the reverse pathway. We first start with the ideal prosthetic scenario, and then we go ahead and check how's the tissue, how's the bone, is it sufficient, is it missing, do we graft and place the implant immediately? But we always want to have an ideal or closest to ideal implant position, because that is very significant for the long-term clinical success of the restorative material, of your ceramic, of your hybrid ceramic, of your zirconia on top of those implants. And nowadays, We don't do fully guided every time, but at least the pilot drill helps you a lot to place that implant as precise as possible. Okay, so moving now into the world of ceramics, which is our most favorite topic, I would say. Dr. Blatz, our chairman, and I, and some of our co-workers published this classification where we divide them in 3 different groups. You might heard the past webinars going in detail on this, but today I would like to show the application of certain materials, certain ceramics on implant supported restoration. So when I got to Penn in 2015 and 2016, I was able to finish this systematic review because I really liked the monolithic restorations bonded to the titanium inserts or bases. We're talking almost 3 years and a half ago, 4 years ago, and the amount of literature review that I found on the topic was very, very limited. Okay, I liked it because monolithic means that there's no risk of chipping, means that I will also have more room because I don't need to share that space between the coping and the layering ceramic. And the tie bases meant that I always had an original titanium component inside the titanium connection. So in my thought process, that was very close to something ideal. Okay, but we had to test it as well. So as you see the results from this literature review, there were only case reports. I was one of those doing those case reports, and we needed more in vitro and clinical studies. So this is what then we moved forward to start working in 2017. At that time, the materials that we had for implant solution blocks, meaning that these are blocks to be milled in the Cerec system that have this screw access hole to fit the titanium bases that are meant to be used with the Cerec system, were PMMA, hybrid ceramic, a silicate ceramic, and an oxide ceramic or a zirconia block. Okay, so we wanted to test these materials and really see what would be the ideal indication. So we used an internal hex implant, and then we looked for the best way to bond to these tie bases. This was published by Dr. Blatt, and it's basically the APC concept, and it's something very important for today's restorative implant workflow because we use a lot of these tie bases. So the APC is air particle abrasion. The titanium, we need to air abrade it with aluminum oxide particles of 50 microns at a low pressure of 2 bars. And if we're using a zirconia as a material, we also need to air abrade the intact surface of the zirconia restoration. Then when we're working with the titanium, because it's an oxide, we need to use a specific primer which contains MDP. That phosphate monomer is what creates the bonding to these oxides, as the silica creates it for the ceramics. Okay, so we need a specific primer that contains MDP, and of course a resin cement. And here you could use different ones, different companies make them. My only advice would be never mix them because we don't know the compatibility between a primer and a cement, etc. So make sure that you use an entire system for bonding to titanium bases. Okay, then we went and did in vitro testing following some ISO standards with the tie bases and different materials. And then we were trying to analyze how we obtained the failures and what was going on there. So this is resin matrix ceramics material, which is VITA enamic. VITA enamic is a hybrid ceramic, and we understood that we had to etch the ceramic in a certain way. We had to apply certain coupling agent to the ceramic and different to the titanium to be able to obtain the strongest bonding between these 2 elements. And I will discuss this in detail later on. We also tried lithium disilicates, and also we tried the zirconium oxide that was available at that time for this indication, which was a first generation zirconia, a very hard and opaque white zirconia, indicated for mesostructures, for custom abutments, not for monolithic crowns. But here we can also see that with the APC concept, we're able to bond properly to this tie base. Okay, so once we apply the APC to the titanium, Then we just need to see what the outside material is and what is the best method to bond to these different types of materials. The great thing of working with tie bases and this type of implant solution blocks is that the fit is prefabricated. We always obtain a perfect fit because those holes are already drilled in these blocks at the manufacturer facility. And then the only thing that we're milling with these 4-axis compact milling machines is the outside of the restoration. The great thing about doing the cementation extraorally between the tie base and the ceramic material is that we are able to remove 100% of the excess of resin cement. If you've read more recent publications on the risk of peri-implantitis due to lack of complete removal of resin cement, that's something very concerning for us, right? We think that we remove all the excess of cement when we make an x-ray, but in the x-ray we only see the mesial and distal surface, but we don't see the facial or the lingual aspect of the implant and implant restoration. So that's why we really like to use tie bases, and we really like to use these implant solution blocks to be able to cement this extraorally and then provide a screw retain solution whenever possible. But if we go one step back and we always work with the digital clone aspect of idealizing the implant position based on our prosthetics, most of the time we have the possibility of creating screw retain restoration. So here we will be having that minimal cement line between the tie base and the ceramic structure around 30 microns, which is really, really good. So for these different types of materials, we need to understand that zirconia is totally different from any type of ceramic. Zirconia is an oxide. It's very strong. It's very hard as well. So when I'm in need of creating a custom abutment that has this type of design, where in the subgingival aspect we want to create concavities to give more room for the material, we need to design these mesostructures very thin. So for the mesostructures and the custom abutments, we only recommend zirconium oxide. Okay, if I'm doing a monolithic screw retain implant crown where I have more material thickness, as you can see in the photo in the middle or in the right, I could use a lithium disilicate or a hybrid ceramic like VITA without any problems. Okay, but our research shows us that when we cannot maintain those minimal thickness warnings, we won't be successful with either of these ceramics, and we would need to go for oxide material like a zirconia. Okay, so this is important, and this will be helping us when we make the decision process. The advantage that I see here with the material on the right, which is the VITA, is that what you mill is what you get. This is a stable material that only needs manual polishing. So the material doesn't need to go through sintering cycle like zirconia or through crystallization cycles like lithium disilicate. So it's a very quick material to work chairside. You can design it properly. If you mill it, maintaining the minimal thickness, then you just go ahead and do your adhesive protocol for the tie base, and you can have a same-day screw retain implant restoration in less than 1 hour. Okay, so those are important aspects to consider. VITA worldwide manufactures 2 different implant solution blocks at this moment. One is the VITA CAD Temp, which I'm pretty sure it's not available in the US market. I'm sure it's available in Europe and in other countries, but it's basically an acrylic block, okay? But it has the same screw axis that fits these tie bases for the Cerec software. And then we have the VITA hybrid ceramic block implant solution, and now we have it in a multicolor block as well, in a longer block, because we found out that sometimes when we are restoring a maxillary canine and there has been some soft tissue recession and some bone loss as well, we could end with a very long clinical crown anatomical crown, I'm sorry. So we need to have a longer block. So VITA has thought about that, and it offers it in a multi-chromatic block, but also in a longer or in a taller block for this type of long restorations, okay? And as we know, the hybrid ceramic is very smooth for milling, and we're only milling the outside, so the fit on the intaglio is always perfect. And you don't have the risk of that variable of crystallization or sintering that could modify the dimension of this material. So I want to go through some of the basics when we are treatment planning on implants. Where would I place the implant? At the bone level, or subcrestally or supracrestally? And now we always need to first consider the prosthetic aspect. So we always make sure that when we're planning, we merge the STL of the digital wax-up as you see it here in green, and from there we would decide the final implant position. So always we need the platform of the implant to have 3 millimeters of soft tissue coronally to be able to maintain that bone at the crest. Okay, so this workflow helps us decide where my implant needs to be placed. Not only the bone condition, but the future marginal position. So this was done by one of our residents, always using computer guided procedure, even though it's pilot drill. And then we can mill one of these provisional materials, and then we can have a high-end provisional restoration the same day. And also with this exact same workflow, we could scan immediately after the implant has been placed and deliver a long-term provisional restoration or interim restoration with VITA Enamic as well, because VITA Enamic, you will just be milling it and you can bond it to the tie base and deliver. And sometimes you see your patient more than 6 months after that, but the advantage of using these type of materials is the soft tissue response, because here I'm not relining with flowable composite and polishing and adding a little bit more for the contour and the critical contour area. I design everything in the software. I just put a block and mill it out, and I can have very nice soft tissue maturation. So this is the VITA Enamic hybrid block. As I said, it comes in the multicolor block. The most apical part of the block is more saturated, and the most coronal part is more translucent, okay? So here, it's also important to consider the minimal thickness when we are designing, for two reasons. One, to maintain the ideal thickness for flexural strength, and also have certain thickness for masking the titanium components. So if you have very reduced restorative space, I might be changing my decision and going for a zirconia that I can mask a tie base and work it safely in a thinner dimension at that cervical area, okay? So it's important that as clinicians, we understand this rationale to select the material the best we can. What I like about Enamic in general is the great machinability. It cuts very fast with the burrs. It doesn't waste too many burrs for making 20 or 30 restorations. It's very economic in that aspect. It's totally dimensional stable because you don't need to crystallize or sinter. And it has a modulus of elasticity between human dentin and enamel. And sometimes when we have bemaxillary cases, implants in the uppers, implants in the lowers, maybe having something very hard as zirconia, opposing something very hard against zirconia on implants which don't have any type of proprioception might not be the best. Sometimes patients could even complain about feeling their prosthetics very heavy when they're very big and they're all monolithic zirconia. So you'll see later on how we also use this material for full arch situations whenever we have a proper indication. So going back to the bonding part, I already explained how to bond to the titanium base, right? We air particle abrade with aluminum oxide, then we apply the MDP primer, okay? And then we will use the resin cement, of course. And if we're doing one of these VITA Enamic implant solution monolithic restorations, after trying, we will clean it in the ultrasonic in alcohol, then we will etch it with hydrofluoric acid for 60 seconds, and then we will just wash it and dry it with air, and then apply a conventional silane, okay? This is a silica-based ceramic, so we don't need to add MDP. Just a conventional silane coupling agent works perfectly with the VITA enamel hybrid ceramic. I did research on this and it was published in the JPD, trying different timings between 20 seconds, 60 seconds, 120 seconds, different post-etching cleaning methods, and we've concluded that 1 minute is the best approach for etching VITA enamel. If you do 2 minutes, it's okay as well, okay? After etching, just water, spray, air is sufficient to clean it and then apply the silane coupling agent. But just as a reminder, never bond enamel without etching it. You need hydrofluoric acid etching for 1 minute. Okay, you can use it for 2 minutes as well, and then apply a silane coupling agent. With that, you will have now a strong bond to both interfaces, to the ceramic side, to the enamel side, and to the titanium aspect as well. Okay, I also published in Dental Visionist, which is the journal from VITA, on CAD/CAM implant prosthetic, implant supported crown restoration made of hybrid ceramics. And basically, when we are thinking about practical step-by-steps, the first thing I do when I'm going to make the intraoral scan, I will remove the provisional restoration or the healing abutment and scan the soft tissue, okay? That will always be my first scan. As you can see here in this photo, immediately after removing the provisional or your custom healing abutment or your conventional healing abutment, we will go ahead and scan the soft tissue. And in this first scan, that's where I will be scanning the interproximal areas of the neighbor teeth, okay? Sometimes we need to analyze to see if we don't have any angulation of those neighbor teeth, because sometimes we need to make a small recontouring on the proximal surface to be able to achieve an ideal interproximal contact area, okay? Sometimes we don't analyze this, and when we're in the design phase, then it's very challenging to create an ideal contact area there. So sometimes I use a red line, fine diamond burr, recontour the proximal a little bit, or a SofLex disc, and go ahead and scan this, okay? Then I can place the ScanPost and send the patient to make the x-ray. And once we verify that the ScanPost is fully inserted, then we go ahead and make the second scan with the ScanPost to capture the position of the implant. But that will always be my second scan. The first one will always be the soft tissue and the proximal areas of the neighbor teeth. Then we will just go ahead and make a conventional scan of the opposing arch, and then a buccal scan as well to get all the different files correlated together, and then we will design the monolithic restoration and mill it with the enamic implant solution block. I like to have both sizes of blocks in terms of the height, so we could reduce the milling time if this is something that you want to achieve in one appointment, and it will be slightly faster if you use the shorter disc, the implant solution, in comparison to the longer one. But also you want to have some of those for those cases where the crown could be a little bit long. And then I always like to try it in first as a cement retain restoration. And once I confirm that I have nice contact points, interproximal contact points, I will clean everything in the ultrasonic, and then I will start with the APC Concept to get the tie base ready, and etching and silanizing the enamic restoration, and then we will go and do the extraoral cementation and deliver it as a screw retain restoration. So when you want to deliver this as a screw retain restoration, remember the first photo here, idealize the interproximal area of the neighbor teeth. Make sure that you have a nice and clean insertion axis for that final restoration. You can visit Dental Visionist at dental/visionist.com. You can download my publication there, if you want to go through it on your iPad later on and go with the step by step. And what am I doing now after many years of using this material and this software and hardware with CAD/CAM? This is something I've been reading from Dr. Gamborena and Dr. Blatz, my mentor, on the possibility of achieving the all at once. This means that are we ready today to be able to diagnose a tooth that is not restorable and we need to extract it and we need to place an immediate implant, and while we evaluate the primary stability of that implant, and if it's higher than 35 newtons per square centimeter, I can then go ahead and place my ScanPost and make the intraoral scan, capturing the ideal emergence profile before extracting completely the fractured tooth, and then designing and milling one of these implant solution restorations that will also help us to maintain the grafting material between the implant and the bundle bone. And I think that the answer today is yes. Of course, there are many variables and not all the cases we will be able to achieve these, but in many, if we maintain a clean protocol, we can start delivering these same day implant solution restorations with these blocks. And then I came back to Costa Rica, I think a year later, and the patient said, you know, I'm going to maintain this crown as my final crown, so I need to start changing the way that I charge for this ones probably, because we see that we don't expect any changes in the soft tissues. Why? Because we are using the time for the osseointegration parallel to obtaining the best soft tissue maturation surrounding this polished hybrid ceramic material. Can I use a PMMA block for these? Sure, you can, and then you can move to a final ceramic restoration. But I think that having this possibility of the implant solution blocks that don't need any sintering or crystallizing, you can have them ready very fast, and they will last much longer than a PMMA. So I think it's a nice option to have them around. Okay, so now I would like to transition to other cases and moving also to zirconia before we jump into the full arch indication. So this is a case I did with Dr. Brian Kasten. He did the diagnosis, the extraction, and he placed the implant, and then he converted this PMMA shell to a screw retained provisional. And then I was referred the case and I started with the prosthetic aspect. So here, I want to take you step by step on how to make the best intraoral impression. So this is a provisional number 9, okay? So immediately after removing the provisional, I will go ahead and scan the soft tissue. I gotta be ready because once I remove that provisional, the soft tissue will collapse and I will lose that, okay? Before we do that, it's very important at the beginning of the appointment to determine the proper shade of the contralateral tooth, because once we get started working, teeth will dehydrate and we won't be able to have the ideal shade selection. So this is always the first step, okay? Make sure the teeth are very hydrated, and I always help myself with good photography, okay? I will use the 3D Master Shade Guide or the classical if it's a very easy case. If it's something a little more challenging, I feel much confident with the 3D Master because I'm basing my selection on the value, on the grayscale. And you can see here the photo on the right side, how we always aim to be exactly on the value. Chroma and hue, we can modify that later on, but the value, the grayscale, is what we always want to be able to hit. We can always also scan the provisional just to track the position of the soft tissue before creating the restoration. This is something very helpful as well. As you can see here, I'm scanning before removing the provisional. And then as I remove the provisional, I have the scanner ready, and I will go and scan, focusing on the emergence profile and the proximal surface of the neighbor teeth. Nowadays, with the newer scanners and newer softwares, we are also able to scan deeper on that socket, around 3 to 4 millimeters without any problems, which makes it very, very helpful to capture the ideal emergence profile for the design of patient is not feeling any pressure, not feeling any pain, and that's also something very attractive, I would say, for the patient, because that restoration is designed accordingly to this position of the soft tissue. So once we have this ready, then we can go ahead and place the ScanPost with the scan body, make an X-ray, assure that the component is fully seated. That still remains a very important step, and we will go ahead and scan clearly, okay? Depending on the type of ScanPost that you're using, most of them, the occlusal part is made of plastic, so it's not reflective and it's easier to scan it, but we gotta make sure that we have a nice and clean scan before proceeding with the design of the restoration. So what I'm doing here, I'm activating the upper jaw, I'm rotating the file, and you can see how nice we capture all that emergence profile. This has a great value for the design of the final restoration. Okay, so here you can see a very nice sagittal view of the design. You can see the implant, you can see the tie base, and we have a screw access hole right at the cingulum. We have sufficient material thickness surrounding the tie base, 360 degrees, and we also have a nice vertical running room to change the design from a circular platform, that's what we have on the tie base, to a very anatomical shape at the CEJ, as you can see here. So implant position is crucial, and it will relate to the success of your final ceramic material. I like to design these restorations myself, and when I think about single centrals, think about symmetry. Okay, so I want to make sure that the zenith position, the position of the soft tissue, is exactly matching the contralateral tooth. The width and the length of my crown is symmetric to the contralateral. And many times when I'm doing this evaluation before starting with the scan, I use direct composite. Maybe I help myself with the proximal area of the contralateral or the distal tooth to be able to idealize the prosthetic space. If my prosthetic space is very wide compared to the contralateral tooth, it is very difficult to obtain something that looks symmetric and looks natural as well. Okay, so we want to make sure that the restoration provides support to the soft tissues without strangling the papilla. So here I like to design it myself, make sure that I don't have more than 5 millimeters from that contact point to the proximal bone there, and that I also have sufficient material around the screw access hole, because the material integration as strong as weakest link. Okay, we are finishing this for publication, and it basically explains the ideal implant position when we are thinking to use these type of tie bases and implant solution blocks like VITA and AMIC. So of course we want to have sufficient distance to the buccal plate, so always try to maintain 2 millimeters from the buccal plate. That will always help us, and we want to have that area for grafting as well. And nowadays I wouldn't go for the widest implant that fits that socket, but for a regular or narrow implant that provides me with that space for grafting to compensate for remodeling of that bundle bone. And then because of the shape of the tie bases, we also need to have a little more distance with the neighbor teeth. So we need 2 millimeters as well, so we are not creating an excessive pressure on the soft tissue and the hard tissue in the area of the papilla as well. Okay, so platform switch implants, not going for the widest implant that fits that socket, will help us achieve these guidelines that will be really, really helpful. And when I'm working in the Anterior maxilla, same thing. I want to have a palatal approach, and I want to maintain those 2 millimeters of space between the vocal aspect of my implant and the bundle bone for grafting. And very important for the tight base is try to have the implant platform at 3 millimeters from the free gingival margin. Okay, if we place the implant too far apically, I would say 5 millimeters, then that tie base might be short for that situation, and a custom abutment would be the best solution. So understanding these since the planning phase will also help you have a better clinical success with your implant restorative materials. Okay, and as I said before, the tie base, air abrasion, ceramic primer plus, and composite resin cement. Okay, in this case, we used a monolithic zirconia. And always remember that when we work with monolithic zirconia, we're using one of the most biocompatible materials out there. Zirconia is being used longer in orthopedics than in dentistry. For hip replacement, it's very strong and very biocompatible. So that area, that subgingival area, we always want to make sure we avoid any glaze down there, and we just polish manually that surface. The clinical crown, of course, you can add some ceramic if you want, you can add some stains if you want, and glaze it for sure. But after you finish the glaze, you get the restoration out of the furnace and repolish that neck of the crown. That subgingival aspect needs to be always polished. So you can see with the soft tissue that is maintained, even a monolithic zirconia can look really, really nice. And what is the key? To make sure you match the value, the grayscales. So always shade selection at the beginning of the appointment. If you're not really sure, I recommend go with the 3D master shade guide because it's based on value. If it's a straightforward case and you feel more confident with a classical because that's what you feel you're faster with, that's fine as well. Okay, and these are other options of monolithic zirconia bonded to tie bases. Nowadays, we have very nice zirconia restoration. So we use them more and more and more. Of course, we don't have these as implant solution blocks. So these ones are milled from pucks, from zirconia discs. So these, I wouldn't consider it a chair-side restoration. While with Dynamic, I can create a same-day final implant supported restoration, or with the PMMA block, I can create an immediate milled provisional restoration. So we really think that understanding the ideal implant position, maintaining the minimal thickness of the material, makes these type of monolithic restorations very, very affordable and also very consistent aesthetic and functional results. Okay, so before we go into some implant complications, these are some photos I took with VITA Dynamic. If you're using VITA Dynamic, remember that this is a hybrid ceramic. You need thickness. Okay, I wouldn't use Dynamic for a custom abutment. I would use it for a monolithic restoration. Ideally, I would say I would use it for the premolars or molars when I have a distal tooth. Okay, that you're going to be very, very safe. Make sure that you always maintain the minimal thickness warnings. Okay, and if you have an extremely heavy grinder, Bruxer that has already fractured PFM or other situations, then we have the possibility with zirconia. But we need to understand that if we have a proper implant that is placed, and if we can bond properly to the titanium base and the dynamic monolithic restoration, we don't need always the highest flexural strength material out there for long-term clinical success. Okay, we do need thickness. So personally, I don't use it for custom abutments. For that, I would use zirconia. And if it's for monolithic rounds, I would use both. If I want to go chair side, I go with dynamic. If I want to send this to an external lab, I would go with zirconia. Okay. Sometimes we have certain type of limitations, like this implant that was placed twice. very facially oriented. And here we cannot go for a screw retain solution. So we need to design a mesostructure that would be bonded to the thigh base. This would be a zirconia restoration, a zirconia abutment, and then we can mill a provisional to see the reaction of the tissue, and then we can mill a final ceramic restoration. So in these anterior cases, I like to mill this first from a CAD temp, a provisional material, and then we can always mill the final restoration from a ceramic, feldspathic ceramic material if this is cement retained solution. Okay, we cannot have screw access hole on feldspathic ceramics. Feldspathic ceramics work well as a biodome, as a full crown. Okay, but not with a screw access hole on them. Okay, so this would be one indication for cement retain when the implant is placed too far facially. And we use the zirconia abutment as we use a normal prep, an abutment to and cement these type of ceramic restorations. Okay, and there are many ways to trick the software as well, but I think that we should put more emphasis nowadays on creating an ideal soft tissue emergence profile, and making these custom killing abutments are very helpful for idealizing the emergence profile of any implant supported restorations. Okay, many speakers don't like to share their complications or failures, and here this is a case we did, and I want to show you perhaps one limitation of the implant solution blocks with the thigh bases, and it's mesiodistal reduced space. Thigh bases in the lower incisors and the maxillary lateral incisors sometimes are not the best choice, because we might not have sufficient distance. That's why we're writing this paper, soon to be published, on the ideal implant placement whenever we are thinking of using thigh bases. You can see here that we don't have those 2 millimeters from the thigh base to the proximal tooth. So this shape of the component will be affecting that bone interproximally, and of course we can lose the soft tissue. So for these type of incisors with limited mesiodistal space, we still like to use a custom titanium abutment and a cement retained crown, and be able to have the best emergence profile from the implant platform to the cervical margin. Okay, so these cases, make sure you have a custom titanium abutment. This is another example. These are tissue level implants, and when these implants are not placed perfectly and they are left slightly very supracrestally, to say it one way, it reduces the resorptive space and it makes it very difficult. Remember that the thigh bases have a polished collar or metal collar around 0.7 millimeters of height. So we also lose that additional vertical distance. Okay, so if you're using tissue level implants, try to place them apically perfectly, so the prosthetic side we don't suffer that much. And in this case, we had to modify the thigh base, creating basically a bevel of zirconia around the thigh base to be able to start slightly apical, of course, without touching the implant and the implant connection. But these things need to be treatment planned accordingly, so we can use the thigh base concept and the implant solution concept without these challenges. So you can see here, this is the Vari base from Straumann, and we created this bevel, and we went with a zirconia restoration that is stronger, and we could manage it thinner, going around that titanium base to be able to close that aspect there. Okay, so moving forward, just to explain about the options that we have with VITA on zirconia. Nowadays, we have different generations of zirconia, and basically what makes these generations of zirconia different one to each other is the percentage of yttria. Okay, so lower percentage of yttria, higher mechanical properties, more opaque zirconia materials, because they will be in the tetragonal phase. higher percentage ethia that will give us lower mechanical properties but better translucency, and they have more cubic face and less tetragonal. Okay, most of the time when we use monolithic implant supported restorations, we're going with the intermediate. We're using 4% each stabilized zirconia, which has sufficient mechanical property for any type of single units, 3-unit fixed dental prosthesis, even 4-unit FDPs. It has a nice translucency for being made as a monolithic solution, and it has both tetragonal and cubic faces. For the VITA solutions, what we have is these 4 possibilities, and we need to always understand these concept of translucency versus strength in zirconia. Okay, so the most translucent zirconia would be the VITA YZT, which means translucent. Okay, then we start getting more translucency with the VITA YZHT and ST. Okay, and the most translucent, but let's say weakest zirconia would be the VITA YZXT, which would have a 5% of ethia, while the ST will have a 4. So if I would need to pick one, I would go with the VITA YZST, super translucent, which is an in-between aesthetic material with nice translucency for monolithic restorations, but a strong material as well. Okay, and just to close this chapter of the classification of the zirconia, we published this on the Journal of Dental Research, and basically, if you're cementing conventional PFC crowns, FDPs with retention and resistance form, you can use any type of cement out there. You can use glass ionomer, you can use self-etching, self-adhesive resin cement, which are quicker options, and perhaps they provide easier removal of excess cement. Okay, if you want to start using zirconia to bond to these tie bases, we need to make sure that we aerabrate, we apply the specific primer that contains the MDP, and then we use a composite resin cement. Okay, and we are seeing now very recently that newer self-adhesive resin cements that have the MDP monomer inside the cement can also bond properly to tie bases. Okay, so we're just presenting our initial research with this type of SA resin cement, but always air particle abrasion. And we've seen as well that if I aerabrate immediately after and immediately go to the cementation, that's where you obtain the highest bond strength. So we don't recommend that the lab aerabrates and then that has been there for a few days until I go and do the cementation. So I think this clinical research, this in vitro research have very high clinical relevance. Okay, we see different cleaners in the market. These cleaners are only needed if you don't have a sandblaster in your clinic. Okay, but if you have a sandblaster, you don't need at all the cleaner, because you can try in cleaning the ultrasonic, air particle abrasion, and the same air particle abrasion is a great cleaning method to that titanium surface. It's actually like a peeling on the skin, and it creates a more charged surface to have a better, let's say, conduction of the primer once it's applied. So fresh air abrasion is still the best today. Okay, implant alternatives, we can also use zirconia for resting bonded fixed dental prostheses. Sometimes we have patients that are 18, 19, still very young for placing an implant, or patients with certain type of systemic complications. We can go ahead and design this with 4% each stabilized zirconia. This is a monolithic zirconia restoration bonded to the tooth with the APC concept, air particle abrasion, primer, and cement. And if we're bonding to enamel, we will always etch the enamel, apply a bonding agent, and then do the final cementation. So We see many patients that come for implants, but we understand that the growth of the maxillaries it still goes on the late 20s. So nowadays we like to delay that implant on younger patients. So these are great tools, great options, patients that might be going to college and they don't want to use their retainer, the clip or whatever, but still might be young for an implant. Then this type of resin bonded fixed dental prosthesis, applying the APC concept are of great help. This is another example, patient going through some chemotherapy at the Penn Hospital. She was referred to us, and then we can go ahead and prep this palatal or lingual veneer, staying 100% on enamel for better bonding. And then we can go ahead and scan it, design it, and mill it. And these ones are always made with a single retainer. We know that teeth move, and something that is bonded to two teeth will have more chance of debonding than just bonded to one tooth. Okay, so always single retainer. On the area of the tooth, rubber dam, phosphoric acid etching, adhesive to the surface, and then the final cementation. Okay, always rubber dam isolation will help us control everything. I would keep the margin of the preparation slightly supragingival in the palatal aspect to facilitate the placement of the rubber dam and actually the final cementation of this type of variation of Maryland bridges. Okay, of course, here we need to design defensively. What I'm saying by this is that I don't want to have any contact in MIP in the pontic site, and I will make sure that the patient moves the protrusive and the lateral movements, and I want to protect the pontic. Okay, and always polishing zirconia will help us maintain a better surface on the opposing dentition. Zirconia is very hard, but if it's smooth, it's not harmful at all. Okay, so always use the red line fine diamond burr when adjusting the monolithic zirconia, and then use the low speed polishers, 2 steps. I use the Brasper kit to make sure that I finish with a smooth surface in the zirconia, and that will avoid any wear of the opposing dentition. So this, I think it's important today. We're talking about implants. These are alternatives because we have certain group of our patients that are not ideal candidates, at least at this time, for the implant restorative solutions. Okay, and now it's raining very heavy here, but I would like to just finish with some concepts of dynamic on the full arch. Okay, so when we are trying to decide to go for an All-on 4, All-on 5, All-on 6, we go with a hybrid titanium frame and denture teeth, or if we go with a full zirconia implant bridge, we need to understand that the maxilla and the mandible are completely different. The mandible moves, it has a high density, while the maxilla is stationary and it has low density of bone. So we cannot apply the same recipe for the maxilla and the mandible in every single case. Okay, based on that, I would like to show you a case we did 5 years ago. Patient came with very bad quality of dental care, abutment teeth in very bad conditions with endocardial lesions. Okay, so we plan to extract the remaining mandibular teeth, and we plan to place 5 implants and convert these immediate denture into fixed provisional. So we went ahead, placed the implant, and loaded that denture. We went and then created the final impression 5 months after with open tray techniques, printing those impression copings, and then we started designing these ideal full arch prostheses. Okay, we understood that we had to recover not only the space for the teeth, but also the space for the lost bone and tissue. Okay, so this is a hybrid case. Here we make a scan of this ideal setup, and then we use a high performance polymer material for the framework, because we feel that sometimes going with full zirconia in the mandible can be very heavy for the patient, and sometimes the occlusion can be too strong, and some patients even complain of a loud noise or clap when they bite as well. So having, let's say, lighter materials in the mandible is always a good idea. Okay, so we use this polyether ketone framework, and then we made a ideal, let's say, cutback, designing perfect preps, and then we were able to design these 12 single unit crowns. And here I wanted something that was as close as natural teeth for the patient, that, let's say, in a way, at least philosophically compensated for that lack of proprioception. But we've seen how patients like the feeling of enamic. So we use enamic blocks. At that time, we didn't have the enamic discs, only the blocks, and we milled these 12 single crowns that will be cemented to this polymer framework. And then we applied light curing composite material for the pink part. Okay, so you can see here the high performance polymer framework, the 12 VITA enamic single crowns, manually polished, following the step 1 at 10,000 RPMs and the step 2 around 6,000 RPMs. I really like these polishers, but never go more than those speeds. And then this was done in collaboration with Jay Black, excellent dental technician in Orlando, Florida. And Jay was using the VITA VMLC, veneering material light curing. So you can paint the framework as an opaquer and then apply the different dentines and the different shades for the gingivas. I'm sorry, not dentines for this case, only the different gingivas with different effects as well. And you can have a very light framework, but with long-term success. So here we have the final restoration, the 6 anteriors that the implants are not involved in those areas. We can cement all of those in the lab, which makes it very easy, no risk at all of having excess of cement. And in the posteriors, as you can see, we have 3 crowns that have the screw access hole. So we will cement those 3 after final insertion of the framework, but the other 3 in the posterior area, we can cement them in the lab as well. So always cementing extraorally gives us the great help that we can remove 100% the excess of the resin cement. I want to run this video and I want to show you how we actually bond to enamic. So this is the enamic crown, okay? And as I said before, the enamic crown is a hybrid ceramic. It contains 86% feldspathic ceramic. So we need to apply hydrofluoric acid etching, okay? We did the research and we know that 60 seconds is sufficient time to etch this hybrid ceramic surface. I like to apply it with a micro brush to make sure that I can control the amount of acid that I'm placing, because I don't want that acid to go on the external surface of the restoration, because it will also etch the outside, and then it will be more porous and it will be able to get stain easier because it's more irregular. Okay, so after etching, wash and dry only, and then we would go ahead and apply a silent coupling agent. As you've seen in the photos and in this video, this is the Panavia V5 resin cement, and the Ceramic Primer Plus has both a silent coupling agent and an MDP monomer there. So we can use it for every type of implant restorative material. So this is how I apply the silane inside the enamic crown, okay? And then we will go ahead and place a new tip, leave the cement, and apply the cement inside the crown, making sure that it's well distributed. And here, I want to apply sufficient material distributed properly with a microbrush or with a resin spatula to make sure that when I seat the crown, I have an excess of cement 360 degrees. That will assure me that I have a proper seal in that area. Okay, so you can see here how easy and how clean it is to cement this extraorally. You can tack here if you want, or just use microbrushes. That's what I use mostly. Just the microbrush and remove the excess of cement, and then you can fully cure. Always when you're cementing extraorally, multiple restorations, I like to place all of them so there's no excess of cement going on the margin of the neighbor crown, and then I cannot seat it completely. So this is very helpful to be able to cement this extraorally. Of course, the ones that have the screw access, if they are made with hybrid ceramic, I would not create a screw access hole directly to this restoration with a handpiece, okay? Because this has 86% feldspathic ceramic, so the material would be affected, okay? We go ahead and find the restoration. We were already bonded this to the tie bases, of course, non-engaging titanium bases for this type of full arch case. And then we go ahead and deliver intraorally those 3 crowns, and then torque everything and cover those 2 screw access holes with the pink composite. Okay, so it's been already 5 years. We've been following this patient, this technique, and everything has been working great. And we are also very closely to publish this case. So these are dynamic monolithic crowns on a Pecton framework, high performance polymer. So I think with this, I would like to close today saying that implant position is crucial for the long-term success of any type of restorative material. If I want to go with monolithic implant solutions, you can use dynamic for full contour restorations. If you're going to go for cement retained solutions and you need to create a custom abutment, always use zirconia, because that will give you more room for a better design, more concave design at that critical contour area, and dynamic can be used as well for full arch implant cases like this one. Okay, so many times I've been working with CAD/CAM technology, and many times people ask me, should I invest or not in technology? Well, I would say that everything is going that way. Most of the materials that we're using now are designed and made only for CAD/CAM or printing. So I think that this is the reality. It's been our reality for 11 years, and I don't see how we could be up to date if we haven't invested on this technology. Of course, we gotta be wise, we gotta commit just to what it's really necessary, make a plan, make a design that it's stage approach. You don't need to go crazy just investing it all at the same time, but make that plan and go step by step. Okay, I would say also to finish today, and I always say this, put more attention to details. I see many clinicians having issues, and it's so easy to just go ahead and complain about the material, the impression material, the cement, the ceramic, or I think most of the time when we have complications, it's because of lack of performance by us, the clinicians, whether it's on the treatment planning phase or on the surgical or restorative side of implant dentistry. So make sure we apply as much attention to every single detail. And of course, we want to also focus on better polishing surfaces, okay? Whether it's zirconia, whether it's hybrid ceramic, whether it's a PMMA, we want to have the best surface with our selected materials, okay? VITA provides a nice polishing kit for anemic and for supinity, and I think that that's the way to go. Make sure we have a specific set for each of the materials that we used, okay? And also understand that all our restorations require maintenance. We have patients that could be compliant during the day, but when they're asleep, we don't know their habits, their their parafunctions. So every single patient receives a scan to start the therapy. As we mentioned, the digital clone. Every patient receives a scan at the end for an occlusal guard to be able to protect our work while the patient is asleep. Okay, so yes, we also have complications for sure, but we try to tackle them and try to reduce that percentage. And this is something that we still consider necessary in 2021. Okay, so follow established CAD/CAM workflows, always use material-specific instruments, never lose curiosity, and try to practice evidence-based digital dentistry. Okay, now more in the age of social media, not everything that we see out there will be something successful for my patients, for all my patients. So we want to make sure that there's some research behind it, that I know the clinical indication and I know the technique to apply that material successfully as well. So training, CE, not only webinars and lectures, but I really believe in hands-on training courses. That's how I learn, that's how I really understand the material and really get the best out of those different materials that we have. So I would like to thank everyone for spending your time with us today. Of course, I would like to thank VITA North America, the whole team, for putting these nice webinars together. And of course, Paul for hosting me today. I've been learning from Paul on the implementation of digital dentures with the VITA Vigo teeth. He's provided us with great hands-on, online trainings as well. So I think that's the only way we can really keep learning, always get out of that comfort zone. And Paul, I would like to go to some questions if we have any questions now.
Yeah, thank you, Dr. Conejo. We appreciate it. Got a lot of really good comments here. People are really excited about your presentation. A couple of questions we have here. This person wants to know, I guess more or less on implant restorations, where or what makes you decide to do anamic versus like a zirconia? What, is there a criteria, something you look for like that?
Yeah, as I said before, if I'm restoring a premolar or a molar that I have sufficient space that I can design the restoration and respecting the minimal thickness, and I don't have excessive parafunctions, I have distal teeth, all those things add up and will help me be very successful with anamic. So for those more of a average cases, easier single unit cases, I would don't doubt of using this. What I would put a lot of emphasis would be on idealizing the proximal contacts for a nice insertion axis of my restoration, my anamic implant crown once it's been bonded to the tie base. Of course, to the minimal thickness warning, when you have that light blue warning in Cerec, always add material there, okay? And then on the other hand, if I'm maybe designing a maxillary lateral incisor or a lower incisor where I don't have enough space and I see a lot of minimal warning, then I might not go with anamic for that case. I would go with zirconia because I can be safe at less thickness because the oxides are just a different material, right? They are very, very strong, but that doesn't mean that I will go every time with zirconia. So also when I have these type of cases where I might like to do let's say semi-permanent restoration or long-term provisional, maybe the patient is leaving for a few months or a year, then anamic works great as well. And when you see them come back, that's their final restoration. I'm not saying it's a provisional restoration, but you can just mill it very quickly and get them out of the chair with something superior than just a conventional provisional. So if you see my presentation approach, Paul, it's one thing, let's say, supports the other. It's not these against these or these versus these. I think we need to have the knowledge and we need to apply it to specific case, right? We cannot just generalize one thing fits all, right?
Excellent. Yeah, I agree. That's fantastic. I've got a couple people here who are, of course, asking for just a quick recap on the bonding. If you could do that for us real quick.
Yeah, absolutely. So remember that we have two sides, right? We have the tie base, the titanium base, that requires air particle abrasion with aluminum oxide particles, 50 microns, okay? I recommend that you place your tie base on an analog, you hold the analog while you do the air abrasion. That helps a lot so you don't air abrade your fingers, or you don't air abrade anything like the connection part, and you can be more specific and you protect the connection. You apply the primer, needs to have MDP. That's what provides the bonding to the oxides. And then the resin cement. If it is a very thick zirconia restoration bonded to a tie base, I would recommend using a self-curing resin cement. In the Panavia V5, I know that the opaque is self-curing, but if I'm using enamic, it's a material that the light can go through, so I could use the dual cure and it's faster and I like it a little bit more. If I'm working on the enamic side, after trying, I would just clean it on the ultrasonic and then apply the hydrofluoric acid etching for 1 minute. If you go with 2 minutes, it's okay, but that's the range. And then you will apply a silane. This is a silica-based ceramic. It's a hybrid ceramic, but it has feldspathic there, so it's silica-based as well. And then you will go with the resin cement. So understand both sides and treat them as they need to be treated, and you'll be fine. The 4.7, let's say, height of the conventional tie base is sufficient. Some people are always concerned about that, but the intimate contact and the prefabricated implant solution block made this intact to fit very, very nice. So just apply these protocols and we'll be safe with that.
Excellent, thank you. I've got one more here that they're asking if you can do a recap on the printed model limitations.
Wow, yeah, that's a great question. Actually, we've been working on that. We're getting ready to present some of our research soon on that aspect. So if I would need to say something very practical, I would say trust your design, okay? Trust your scan, trust your software. Try to idealize your proximal contacts when you design, okay? And if you want to 3D print something just to place a restoration in a model, to stain and glaze, that's fine. But make sure that we understand that the intraoral scan is the first step and it's more accurate than materializing that file in a 3D printer. I'm not saying all 3D printers are the same. I'm not saying 3D printer is useless, but for high precision dentistry, okay, I would focus on having my scanner well calibrated, very clean, the scanner, scan as clean as I can, and trust the design process. Of course, in the lab side, I do lab as well, it's nice to have a model, but if I don't see a perfect fit of my mill restoration on that model, I will use a scalpel blade and remove a little bit from that printed model until I can fully seat the restoration or finishing or layering. Try to use as many ScanPost as you can, as many downloadable libraries where you can insert the lab analogs, but never try to scan abutments, okay? Never try to scan conventional abutments, because that's where the accuracy starts to drop down, and then that'll converts into more chair time, and sometimes it's frustrating as well. So yes, I use 3D printing, but I understand the limitations of it.
Great, thank you. I think that kind of wraps it up for us here. That's most of the questions. Thank you again. I am going to switch back over here. real quick. You guys see my screen there? If you guys have more questions about the pricing on materials, go ahead and contact your VITA rep. They can help you out with that. Do you have more learning coming up with Dr. Conejo and several other speakers? So you can check out our course calendar. And we just covered questions. Let me give you this one real quick. So again, if you've got more questions, please feel free to contact us at the help desk. And also, this will be recorded and will be available on our VITA North America YouTube page. If you guys need it, we will send you a link. And thanks again for joining us. We look forward to seeing you guys on another VITA learning webinar.
Thank you.